Madam Stella, okay? What happened? She used to attend lectures now.
Yes, I don't know. I don't know
She
what.
will join us very soon, sir.
Please, those people who are not in class, please, let us, at least we have at least 10 in the class.
Maybe we can reach out to them.
Please, call one person that's supposed to be in the class. Tell them that the lecturer is waiting for them in the class. Let me wait.
We'll do that.
Then, while we wait, okay, let me wait so everybody can listen to the instructions.
Good morning, everybody. Hello, good morning.
Good morning. Good morning.
Oh yeah, I couldn't hear anything. That's why. Good morning, sir.
Good morning. How are you doing?
I'm fine, thank you, sir.
Just a minute.
Fine, thank you, sir.
You're
How are you,
welcome.
sir? Yeah, thank you, sir. How are you too, sir?
I'm good.
Okay, sir. So I think we are waiting for others to join, right?
Yes.
Okay, sir.
How many do we have in the house now?
I think we have 9 people.
We have 9 in the house.
Okay. Now remaining 4 persons.
Okay, sir.
Okay, can you see the screen I shared?
Yes, sir.
Yes, sir.
All
Yes,
right.
sir.
So somebody have dropped also. We have 8 now, but no problem. I want to welcome each and every one of us to this class. Okay, and
Yes, sir.
we are far behind schedule. Like I really put the order about 3 weeks ago that I always like to take about 90 to 95% of my lectures, and the most important is not just going through the getting the certificate. But the most important is that for you to be able to refresh our memory to see what we've learned in, the time past, to refresh our memory and then to be able to pick up one or two important information in course of our study. And I wouldn't know. Last week I was busy. I expected, and like I told you that almost every weekend so ought to be, doing one lecture or the other. And I consider that a lot of us are very, very, very busy. Okay, so it's not like an adult education. So we need to, give an opportunity for over the weekend to make sure we are all that is we are doing. So I'm of opinion that is there any possibility? I want to ask to the class now. Is there any possibility for us to have lecture later in the evening today or tomorrow evening after the church service? Which one do you prefer? Because we have a lot of, ground to cover. And between now and December, I would love us to at least to take, to do about 80% of the total work. Even if I don't have any lecture again, they can set a question for the exams. So I want to hear your opinion and your view. Is there any possibility for us to have a lecture later today? Maybe around for 1 hour, 30 minutes, just for a lecture, or tomorrow, Sunday, anytime from 4-5 tomorrow. So the floor is open for your comments, your opinion
Tomorrow will
before we
be
start.
okay, sir.
Is it?
Tomorrow evening will be okay, sir.
Okay. Please mention your name when you are. Who is okay? Okay. Okay.
That's Mrs. Okay.
Miss. Okay. Okay.
Okay,
Yes.
Stella. Okay,
All
Stella.
right.
Mahmoud
Hello.
Olowo,
Tomorrow evening.
I think I
Hello.
want to support tomorrow evening as well.
All right. All right. Okay.
My name is
Yes.
Mary Okwala.
Okay. And
Tomorrow
Mary took
evening.
my class. You miss my class a lot. I
Until
always
I play golf. Ni.
go to
Ìwọ
Ekiti
ló
for
mọ̀.
party. You go to play golf.
Ọ̀gá mi ò ní sọ nǹkan kan mọ́. Mi ì sọ̀rọ̀
Okay.
mọ́.
So, but I don't like students missing my class because the class will be very, very interesting. And most of the things we learned before, you don't want to go through them and then look at what you need to do. All right. Today, this is CPH 503. And if you look at the course outline, it talks about the major thing. If we are going to talk about, kidney, we're going to mention liver. We're going to see most of the things that happen in the kidney. And in chem part, I used to tell my students, there are some important organs in the body you need to pay rapt attention to. And number one is the kidney and your liver. In chem part, you'll be able to cover those, heart also, be able to cover those specific or these organs and what are the most likely the markers used in diagnosing these particular organs. We are good to go. Okay, so but we want to look at kidney. What is kidney? Please don't omit because I want to make the class interactions. We have our questions, we interact. This is not just where the lecturer will be talking and talking. Most of us, we specialize in chem part. We do all this almost every day, on daily basis. So I want us to interact. What is kidney? What do you know? What can you tell me about kidney? What do you know about kidney? What is the function of kidney? Anyone, please. Feel free. If you want to read my note, you can read. Tell me. Just open your mind and want to make the class interactive session.
Yes, I think the major function of the kidney is to excrete waste products from the body.
Yes. Another person again. Everybody must say something. All of us, everybody must say one thing or the other. The function of kidney, I want to know, please. Yes, Mr. Olagunju.
Also,
I'll be calling him now.
Good morning.
Also, sir.
What can you tell? What are the function of kidney?
Okay, kidney maintain pH of the body system. That is
Yes. Mr. Stella Olusola, okay. Yes. Is it okay?
Yes,
Okay.
sir. Kidney.
Yes.
Okay.
Okay.
Kidney regulate the blood pressure. The blood pressure of every
Exactly.
kidney.
Good. Ms. Okola, what can you tell me? What are the function of what does a kidney does? One of the functions of the kidney.
I've just spoken, sir. I'm the first person.
Yes. Lawa Wasiu.
Yes, sir.
What are the function of the kidney? Yes.
Yeah, good morning, sir. The kidney starts to produce hormone.
Exactly, correct.
Yes, sir.
Then Mrs. Wachuku Chidima. Madam Wachuku.
Right, sir.
We can't hear you. Okay. Thank you so kindly. The kidney, in a man, we have 2 kidneys in the body. And the kidney is located at the back of the lumbar vertebra in the human. And for men, it's about 12 centimeter long in men. And it weighs about 150 grams in men. And in women, the gram is about 135 grams in women. That means that men's kidney are... Please
let us mute.
Mute yourself. So the kidney in a man is bigger than that, slightly bigger than that in a woman. Our kidney is divided into 3 parts. But here at your level, I leave it at divided into 2 parts. We have a cortex, we have a medulla. I will show you all. Okay, let me scroll down the picture of the kidney. All right. Can you see this picture clearly?
Yes,
all right,
sir.
you can see, look at my cursor. Look at the medulla. You can see the space of the medulla. Then see the cortex. See where cortex is. The kidney is divided into 2 parts. But in the element, when I'm teaching undergraduate students, I say it's divided into 3 parts. You can see the urethra, the one that connects the medulla to urethra that lead to bladder, is the 3rd part for the undergraduate student. But at your level, I will leave it as kidney is divided into medulla and cortex. Is that taken? All right. So when you look at the kidney has nephrons. Every human being have 2 kidneys. And this kidney is contained majorly in nephrons. Each of the kidney contain from 1 million to 1.5 million nephrons in each of the kidneys. And the nephron is the functional unit of the kidney. And what are this kidney? The nephron? What does it do? Is a function that everything that happens about ultrafiltration, about selective reabsorption, it's happened in the nephrons. And the nephron is equally divided into three parts. We have Bowman capsule. We have glomerulus. We have Bowman capsule and glomerulus that are together, like a bow, right? Then we have proximal convoluted tubule by your right. And then the loop of hair, the end are curved, loop of hair, and then we have distal convoluted tubule. And then from distal convoluted tubule, there's a collecting door that leads out to the passage of the urine outside. Okay, so we are just looking at the physiology of the kidney, the anatomy of physiology. How does it look like? How does it look like? And now, the main function of the urinary system is at its component to remove metabolic waste, as you said, is to remove the waste. The waste, everything in the body system will be taken through the afferent artery into the bone marrow capsule. And the bone marrow capsule, there are 2 function that happens. One, ultrafiltration. And how does the ultrafiltration happen? Ultrafiltration, there are pressure mounted on the bone marrow capsule. There are about 3 pressure there. There's occultic pressure, there's the hydrostatic pressure, and the efferent pressure that are mounted on it. And what happened? All the waste product is coming from every part of the body is being filtered into the collecting dot. Okay. And another function of the kidney is to regulate blood volume. So I'm going to get there. Regulate blood volume and composition. That means electrolyte, potassium, calcium. They are adequately represented. Another function is also it regulates blood pressure. Somebody mentioned it regulates blood pressure. How does it regulate blood pressure? We're going to get to it. We're talking about renin, angiotensin, aldosterone system, RAS. They are very simple. I'm going to take us step by step how those things happens. How does IBP bring about water retention, bring about dehydration, bring about hydration? How is all those things happen? We get there later in the course of the lecture. Also, it produces erythropoietin. That the blood is being produced in the kidney. It's being produced in the kidney, and it synthesizes calcitriol. That is vitamin D2. And looking at this pictorial, you can see the kidney shape. The kidney is being shaped. And you can see the urethra, the top part of the urethra connecting with urinary bladder. I can see the urethra, the one that leaves from the bladder down outside. That's a diagram of the urinary system. And like I said before, that each kidney consists of about 1 million to 1.5 functional units called nephrons. And it's composed of a renal capsule, renal capsule. That is Bowman capsule and glomerulus together, just like a bow. Okay. And we have proximal convoluted tubule I've mentioned. We have a loop of N and distal convoluted tubule. And look at this, the next diagram. You can see the proximal convoluted tubule. You can see the Bowman capsule. The Bowman is just like a bow, like I told you. You can see the Bowman capsule. You can see descending limb of loop of N descending. You can see the loop of N, the curve part of the nephrons, and they can see ascending limb of loop of N, and then you can see distal convoluted tubule. Don't forget Bowman capsule, PCT, that is proximal convoluted tubule, loop of LP, and then distal convoluted tubule. Those are the three major parts that the nephron is divided into. Like we said, kidney is highly vascularized. That means the blood vessel is full with a lot of blood vessels. Okay, and then the blood enters the kidney via the renal arteries, a branch from the abdominal or aorta, and branches into the segmental, interlobar, and arcuate interlobar and afferent arteries. Like I told you that all the waste product from the body system, including the blood, is coming into the nephrons through the afferent arteries. So when you are doing your diagram, maybe I ask question in the exams, although I'm going to ask technical question, I won't ask direct question at your level, So it comes to the bone markers with afferent arteries. That all the waste products, urine, sodium, water, potassium, urea, ammonium, is coming through the afferent artery into the Bowman capsule. The afferent artery bring blood to the glomerulus. The glomerulus is composed of fenestrated capillaries. That glomerulus, I was saying, fenestrated, that's a tiny holes in the blood capillaries in the glomerulus, where filtration occurs. And blood exceeds the glomerulus via afferent artery. Where after the waste have been removed, everything that is relevant, nutrient, it will go through out of the from the nephron through efferent arteries. It comes through afferent A, then go out through efferent arteries. The efferent artery join the peritubular capillaries at the arterial end of the capillary bed. From there, blood continues to the venous and to the capillary bed, we join to interlobular. That is anatomy of the nephrons, the detailed anatomy of the nephrons. I want us to keep abreast with it. Okay, now the picture I've shown you this picture. That is an example and pictorial of a cortex. Now I want to look at the function of the nephrons. What does this nephron does? Remember that I told us that each kidney we have 1 million to 1.5 million nephrons. So for example, if you say somebody had kidney problem, what happened? Suddenly, maybe somebody is going to do kidney transplanting. That means the two kidneys has failed totally. If one of the kidney failed, one part of the kidney and the other one is working, it can still last you for several years, 10 and several years, So, and if the kidney is failing, there are symptoms, deadly symptoms, That is why as a person, we need to be very cautious of what we eat, what we drink, what we get into our body systems. Okay, so when you, I used to tell my students, one of the things you can do every morning you wake up is to hydrate yourself by taking enough water. Each time you wake up, if you don't have access to warm water, take 2-3 glasses of water early in the morning. If peradventure there's light, you can buy water, take a warm water for you. And if you can, for those people that know or hear about alkaline water, preferably it is better for you to take alkaline water in every morning. If you take alkaline water, it's good. Most of the problem we have as a human being is caused by the acidic nature of the water we take. Our bottled water, our pure water, the water we buy every day. Go take your litmus paper check. Is more acidic in nature. And most of the problem we encounter in our physiology and in our body is caused by this, a lot of hydrogen in the water we take. So advisably, if you can avoid or you can access alkaline water, you can try the alkaline water. I've tried it. For almost 1 year, I've never taken paracetamol, and it's working for me. So I would advise to get hydrated. I mean, get hydrated. You don't need to. It's not when you are testing, you need to take water. Water is a therapy. If you can practice water therapy every time, it enables you, ensure that you pass out a lot of waste product in your body systems. Even when it's raining, every 30 minutes, you can need to take water. You hydrate your body systems. So it enables your body to function optimally and efficiently. Okay, so water therapy is very, very good for most of us that not be taking water. Or maybe you are going out, must get a bottle of water, a water bottle, and take water intermittently, for your body to be dehydrated. Now, back to our main course. We want to look at the functions of this nephron. Like I said, nephron are the functional unit of the kidney and perform a series of processes. We want to look at the process number 1, filtration. Start from at the glomerulus. When you talk about filtration, what happened? There's a pressure mounted, like I've explained before. There's a pressure mounted on the glomerulus. And the pressure, we have occulting pressure, we have endostatic pressure, and we have efferent pressure. 3 of them measure together. I wish if I'm in class, I'll be able to draw and show you how those things happen. So when this pressure being mounted on the glomerulus, what happened? A lot of filtrate, the filtrate will pass to the proximal convoluted tubule. Okay, and what are these filtrates? We have water, we have ammonium, we have potassium, we have electrolyte, we have so many things that are being filtered into the glomerulus. And from the glomerulus, the filtrate will pass through the proximal convoluted tubule, then to the loop of N, and then to the distal convoluted tubule. As filtrate is passing through the tubules, the absorption is taking place. And I told you there are 2 processes. Number 1, ultrafiltration. You can say filtration or ultrafiltration. Number 2, selective reabsorption. We're going to look at it in detail. Selective absorption. And I want to assure you this question must come. It's one of the questions that will come in the theory. So pay rapt attention and read about it. So now we'll talk about filtration. Why? Because the pressure is mounted on the glomerulus, and the filtrate, everything that is filtrate, what are the combination of the filtrate? You must measure them: ammonium, water, mineral resources, measure them: potassium, calcium, chloride, bicarbonate, all of them, they are there, they are filtered. Now, in the selective reabsorption, let's look at this picture. Let me show you this pictorial, the top picture. All right. So look at, can you see this picture now?
Yes, sir.
Yes, sir.
All right,
Yes.
Look at this picture. Look at this picture now. You can see that, you can see the bone marrow capsule, right? Let me see use my cursor. You can see the bone marrow capsule. And you can see this is a proximal convoluted tubule. This is proximal convoluted. What happened in the proximal convoluted tubule? You can see all these glucose, amino acid, protein, vitamin, lactate, uric acid was reabsorbed, was pressure, due to the pressure. They were all filtered into the bone marrow capsule. And from here, all these ones are selectively reabsorbed. Glucose is selectively reabsorbed. Amino acid selectively reabsorbed. Protein, vitamin, lactate, urea, and uric acid. They are selected. They are reabsorbed back into the bloodstreams. Okay, and then when you look at the loop of N now, this loop of N, urea, uric acid, creatinine, and some drug are selectively reabsorbed. Okay, they are selectively reabsorbed back into the tubules. And look here, this stack of little tubule. You can see sodium, chloride, bicarbonate, and water. Here, they are selectively reabsorbed back to the bloodstreams. This is the collecting dot. You can see this, my cursor, collecting dot. You can see, and out. So now let's go back to the ultrafiltrations. Selective reabsorption. As soon as the filtrate enter the proximal convoluted tubule, reabsorption begin from the proximal convoluted tubule and continue the length of the tubules, including the collecting dot. Most of the fluid is reabsorbed, like I told you, selective reabsorption, and remaining secretion is called urine. When those things have been, what is useful to the body system is being selectively reabsorbed back into the bloodstreams. The remaining leftover in the collected dot is just urine, pure urine, concentrated urine that's remaining there. And number 3, the urine is then transferred to the collecting duct. Urine passes from the collecting duct to the minor calyces, then major calyces, renal, pelvis, and ureter. And the ureter muscular tubule line with transitional epithelium propel urine towards the urinary bladder. The urine enter the posterior part of the posterior part of the urinary bladder, two opening, where urine is stored until it is time to urinate. The urethra conveys the urine outside the body. Number 4, the female and male urinary system are very similar in structure but differ in length. Male urethra is about 4.5 times longer than that of female urethra. An average of 800 to 2,000 milliliters of urine are normally produced every day as in an adult. The final volume of the urine varies according to the fluid intake and kidney functions. If somebody is having a kidney problem, it affects the amount of urine produced a day. Okay. In summary, the kidney, it filtrates, it reabsorbs, it secretes, and excretes waste product from our body. That's the function of the urine. It filtered, it reabsorbed the item that is good to the body, and it secretes some hormone that's been secreted in the kidney, the nephrons, and then excretes waste product from our body. Now, physiology of the nephron. Like I told you, this afferent arterioles, this efferent arterioles, and what happened, the procedure of filtration, reabsorption, secretion, and excretion. Those are the 4 things that happen in the nephrons. You can see the Bowman capsule, you can see the filtration, you can see that arrow. Look at that arrow. That is what is being filtered into the proximal convoluted tubule. Okay? And down to the loop of end, and then the stuff of convoluted tubule. This is the physiology of for better clarity. All right. I've talked about reabsorption of those items. Okay. The kidney are vital organ responsible for maintaining homeostasis by filtering blood, excreting waste products, and regulating blood fluid, electrolyte, acid-base balance of the body. All right. Then also play a role in hormone productions. So we want to look at the hormone production aspect. Please pay rapt attention. This question may come in. Write short note on renin-angiotensin-aldosterone system. Write short note on renin-angiotensin-aldosterone systems. And each time I ask you question to write short note, there are basic things I'm expecting from your question. Those questions, there are 4, A, B, C, D. And that means that each one will be 2.5 marks. And when you define what is the full meaning, you define what is renin-angiotensin-aldosterone systems, you get half mark. Explanation, you get half mark. The example, second example is half mark. That's 1.5 over 2.2.5. So it depends on some persons will write, they score this thing, they will write 2-3 lines. No, I want the detailed information on it. As you listen to the class as I taught to, I want give me detailed information for you to get the 2.5 marks. And like I said, please, each time you are answering the questions, answer the questions you know best. I can see some of you are very good, some of you are very sound, they are very intelligent, and very, very smart. Most of the people in the class, they are very, very, very sound. Why? Because each one of us, you have 50 billion cells in our body system, in our brain, 50 billion cells. So how do you use your cells? Okay, so what I'm saying is that pay attention. Each time you see write short notes on my question, you must pay attention, the definitions, descriptions, the example, what I'm talking about. You must, everything you discuss must give me an example. You can tell a story. That's almost time when I'm teaching, I use a case study to describe or to explain better. So for you to earn 2.5 marks. I want to congratulate all of you. Everybody did well in the last first semester exams. Almost everybody, just 1 or 2% that I didn't get A. Almost everybody, I was surprised. And when I'm marking, I just to know few people that names I'm calling. They did very, very, very well. They did. And 2, some person in the class, their handwriting is, oh my God, is loving. I'm a lecturer that I love good handwriting. When I see your handwriting is good, like Madam Stella, okay, Olusola, okay. Handwriting is very, 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 very good. If I give 5 marks, 5 extra marks, I add it on the top of your notes, 5 marks, you have a good handwriting. And those who don't have good handwriting, go and get 2 exercise book and begin to improve your handwriting. There's never time enough for you not to learn how to write well. So if you don't have good writing, please improve on your handwriting. I'm in love with the wonderful handwriting. So please take note of that. Okay, let's go back to our lecture. I want to look at how the body regulates BP, how it regulates hormone in the body systems, how it control blood pressure regulations. When you talk about renin, angiotensin, aldosterone systems, what happened? What happened is that this hormone renin is being released from the juxta glomerular cells in the kidney. Renin is released, from the kidney from these juxtaglomerular cells. And what does it do? What does renin does? It converts angiotensinogen in the liver to angiotensin 1. Renin acts upon this angiotensinogen and converts it to angiotensin 1. Okay, and with the help of angiotensin conversion enzymes, it converted to angiotensin 2. And this angiotensin 2, what does it do? What does this angiotensin do? Angiotensin 2, what does it do? It causes, a vasoconstrictions. Okay, vasoconstriction, and then it simulates aldosterone releasing aldosterone. There is an hormone is being released, and when this aldosterone is being released, what happens? It will cause selective reabsorption of sodium and water. It causes selective reabsorption of sodium and water in the nephrons. Okay, and 2, what does this angiotensin does? It stimulates antidiuretic hormone, ADH. It stimulates antidiuretic hormone. And when there's vasoconstriction, I first mentioned vasoconstriction, what does it do? It makes the normal blood vessel, it will narrow the blood vessels. When the blood vessels narrow, okay, it causes what? The heart will be pumping blood with what? With force. It will enhance the heart to be forcing blood to move because the blood vessels is narrow. What happened? Because there's a vasoconstriction, all the blood vessels have been narrowed down, okay, due to the releasing of this angiotensin 2. And we said also angiotensin stimulates antidiuretic hormone. What does antidiuretic hormone does? It signals nephron connected dot to be more permeable to water. When you talk about selective absorption, one of the examples you need to give to me is that antidiuretic hormone is released. Okay, when this hormone is released, it will send a signal from the hypothalamus to pituitary gland to stop release of what? Antidiuretic hormone. Let me take it one step out of the other. Let me start all over again. I say renin is released. Okay, renin is released. It causes angiotensinogen in the liver to convert it to angiotensin 1. Then from angiotensin 1, ACE, angiotensin conversion enzyme, will convert angiotensin 1 to angiotensin 2. And when this angiotensin 2 is being released, okay, it brings about vasoconstriction to reduce the blood vessels. It makes it more tiny. So to cause the heart, the blood pressure to do what? To pump with much pressure. And that's those things that lead to high BP. Okay, and then another function of this angiotensin 2 is to stimulate aldosterone release. When aldosterone is being released from adrenal cortex, what happened? It promotes the selective reabsorption of sodium ion and water, in the tubules. Number 3 functions, it stimulates antidiuretic hormone released. And what does it? ADH hormone, what does it do? It increases water permeability. A selective reabsorption in the collecting dot. All right. So we want to look at key function of the, like I mentioned, for filtration, removal of metabolic waste like urea, creatinine, draw from blood, then reabsorptions, selective reabsorptions, return of substances like water, glucose, amino acid, all those things that are useful to the body system, they are selectively reabsorbed back to the blood. Also excretion of excess hydrogen ion. I'm going to talk about it, how there's hydrogen, ion, water, acid, water, balance, alkaline water, acid balance in the body systems. Excretion of excess hydrogen ion, potassium ion into the urine. Also, number 4, formation of urine to remove waste. The method, this procedure I'm just explaining, that how the kidney regulates blood pressure through the renin, angiotensin, aldosterone, RAS systems. I've just explained. RAS is a crucial cascade that regulates blood pressure and fluid balance. Let us see how it works. I mean, the important, the objective of this RAS function is to what? Is to maintain blood pressure and ensure adequate perfusion of organs. Number two, it triggers, activate when blood pressure drops, blood volume decreases, and sodium level are low. In adults, once you are above 50 years and above, the blood pressure, most of the persons, their blood pressure are relatively is high. What happened? If the blood pressure is high, when they give, some people they place them on drug. When they take those drugs, is to carry out this function, the renin-angiotensin aldosterone system to regularize the blood pressure. How does it happen? Number one, like I've explained, renin is released, and this renin is produced in juxtaglomerular cells in the kidney. It triggers blood pressure to drop. When the blood pressure is high, and hypothalamus releases renin, okay, it will bring about, it will activate angiotensinogen into angiotensin, convert angiotensin 1 to angiotensin 2, by ACE, angiotensin conversion enzymes, like I've explained. Then what is action of angiotensin? Where I've mentioned vasoconstriction, narrow blood vessel, increase blood pressure, stimulate aldosterone release from the adrenal cortex, promote sodium ion and sodium and water retention. It stimulates antidiuretic hormone, vasopressin, enhance water reabsorption in the kidney, and increase thirst. Okay, promote fluid intake. All right, then aldosterone effect. What does aldosterone do? What does it do? It acts on the distal tubules and collecting duct of the kidney. That means there it increase in the distal convoluted tubule, close the collecting duct. Sodium is being reabsorbed. Potassium is being excreted from the systems. The potassium will go into the waste product, while sodium will be reabsorbed back to the system and increase water. Reabsorption also, water follows sodium, increase blood volume, then raise blood pressure. You want to look at what are the clinical relevance. Hypertension, over activation of RAS can lead to chronic high blood pressures. If the renin is over released to the blood systems, the blood pressure will be high. Heart failure. RAS contributed to fluid retention and increased cardiac workload. RAS contributed to, because when it releases constant release of renin that work on the angiotensinogen and conversion from angiotensin 1 to angiotensin 2. Then medication. If you want to inhibit this angiotensin conversion, if this enzyme be eliminated, those are the sample of drugs that eliminate angiotensin conversion, ACE, and enalapril. Danopri, 5 milligram, 10 milligram, depending on the level of the hypertension, the value. Also, we have ARBS, the angiotensin receptor blocker, like losartan, phenol 5, all those drugs. Angiotensin receptor blocker, they block angiotensin for conversion, angiotensinogen conversion. Okay. Then we have aldosterone antagonist, that is lactone, And then now the next one, acid-base balance maintained by bicarbonate reabsorption.
Hello, sir. From my hand here, can you longer hear you, sir?
I think it's out, possibly network issue. Yes.
All right, thank you, sir, Mr. Captain.
You're welcome. You're welcome, sir.
Can you hear me?
Yes, you can. I can hear you,
Yes,
sir.
sir.
I don't know what happened to the. So any question whatsoever for the first, I mean, the one we've taken already. Any contribution, information? Yes.
Sir. Hello.
Yeah.
Hello, sir. Yes, my question is on the alkaline water you were talking about.
If you are
Can
not,
we,
if you are not talking, please mute your. I mean, you can only unmute when you are want to raise something, want to talk. Please go ahead. Go ahead. Now.
hello, sir.
Your
Go
background
ahead.
is cracking, man.
Is it possible for us to maybe add a pinch of salt to the water early in the morning and alkalinize it?
That's not alkaline water though.
Yes, sir. For improvisation, sir, because not everyone would have
It's
the
not.
facilities to get alkaline
You
water.
can access there's some facility that produces. It's not costly now. 5 liters is about 500 naira a day. 5 liters, 500 naira a day. So, but to me, when you add a little salt, how do you measure the salt? How do you measure the concentration of the salt you add into the water? Is that doesn't to me? It doesn't make it alkaline. If you cannot get, just take ordinary water. Take your ordinary water. Cannot get alkaline water.
Adding salt to water will even cause dehydration, so I think it's not advisable to be drinking
It's not even
salty
good.
water.
How we put in salt and water?
Yes, no.
All right. Any further clarification, review, information, or whatever before I proceed? All right. In the absence of no, we want to look at acid-base balance. How does the body balance the acid nature and the base nature of the body systems? All right. So the acid-base balance in the body is tightly regulated, and the kidney play a central role through bicarbonate reabsorption and hydrogen ion excretion. Through bicarbonate, I darken it, I bold it. Mr. Fasasi, sir, class rep. Ms. Okunola.
Yes, I'm with you, sir.
This is exact note you have about. Is any little different for this note?
No,
You have
no,
this
sir.
exact note.
Yes, you sent it to me.
No, I update my note almost every time I want to give lecture. Update. So I highlighted. I mean, all those people I bold, is the bicarbonate reabsorption and hydrogen ion excretion. Let's go. How does it work? How does it work? One, bicarbonate reabsorption.
Excuse me, sir. Sir, we can't, you are not sharing your screen, so we can't see what you are discussing, sir.
Okay, Duro. Thank you for calling my attention.
I thought it's from my own hand before.
Then I don't have this current one we are doing, sir.
Don't worry, I will. In the same thing, I told you I update my note every minute. As I'm leaving, I want to teach. I update it. I read textbook and I improve on my note.
Okay, it will be better we have the updated fashion, sir.
You know, like Kawesi now. You should go and do research. Go and take. How many of you have teas?
I have the soft copy.
I have the soft copy too.
I do. I have.
So if you have a teas, everything, just take your book and read go to physiology of the is detail. Just you get everything I'm talking about. Straightforward. Is it shared now?
No, sir.
Not yet, sir.
Microsoft, yes. Okay. Can you see it now?
Okay, sir.
Yes,
sir. Thank you, sir.
All right. So, so if the former note I gave to you is not updated, anyway, I've sent to you. There's no problem. I don't think whether some people read this. We need to be reading. Apart from that, I'm giving to you because I believe most of you are more knowledgeable than I do. You are better than me. So I'm just sharing my little experience or little I know.
Little experience again.
So let's look at how does body regulate acid-base balance. How does it regulate it? Please don't forget, they say there's a bicarbonate reabsorption, and that's the second function of the kidney. There's a selective reabsorption. What we need to pay attention is to get calm. We should know where in the nephron that selective reabsorption of this bicarbonate and hydrogen ion take place. Is that where we need to pay attention? Number one, bicarbonate reabsorption. I call it bicarbonate selective reabsorption. These occur mainly in proximal, anywhere you see me highlight, bolding, is a critical information you need to be part of. The bicarbonate is reabsorbed in proximal, the first part of the nephron, proximal PCT, proximal convoluted tubules. Then glomerulus, fetal bicarbonate must be reabsorbed to prevent loss. Reabsorption help buffer excess acid, like most of us maybe from the stomach. From in the stomach we have hydrochloric acid, right? Most of those hydrochloric acid, they find their way into every part of the body systems. So when you take enough water water circulation in the body systems, the bicarbonate in the body system, maybe from the food source, from other sources, maybe from water, they will be reabsorbed in the proximal convoluted tubule. And the reabsorption helps buffer acid. So acid has excess acid we have in the body. Like I said, when you take pure water, you take bottled water, the acidic content is higher than in alkaline water. In alkaline water, we have pH of 9. We have pH of 11 for those people that have cancers. Those people that have cancers, we produce water of pH of 11 to them. When they take that water considered for 2-3 months, in fact, the growth of the cells, it will be reduced, and they can live a longer life. So the excess of this bicarbonate is to reduce the inflow, this hydrogen ion that is present in the body systems. And the kidney reclaim nearly all fetal bicarbonate to maintain a normal blood pH. What's the normal blood pH? That is 7.35 to 7.45. That's step one. Step two, hydrogen ion excretions. Hydrogen ion excretion, are secreted into tubular fluid, especially in distal convoluted tubule. So it's not the acid that is coming from the stomach alone. This hydrogen ion is secreted in what? Distal, third part of the nephron, distal convoluted tubules, and collecting dot. Hydrogen ion are being secreted from there in the body, from those tubules. This process helps eliminate excess acid from the body systems. And hydrogen ion excreted is titrable acid or bound to ammonium to form ammonium. To form ammonium. If you see where people maybe a toilet where they build as a toilet, all of us know the fragment of ammonia, is foul. Smell. You see when somebody's constantly where they are urinating, you see how you can't stay there for a minute. It's choking, and the hydrogen ion bound with ammonia to form ammonium. Take note of that. Then the supporting mechanism, what they call supporting mechanisms that happens, for this acid-base balance in the body systems. We have what is called carbonic anhydrase. Carbonic anhydrase. This catalyzes the conversion of carbon dioxide and water into hydrogen ion and bicarbonate inside the tubular cells. This supporting mechanism happen in the tubular cells. The tubular cell, where there's selective reabsorption, so all those things that was filtered, they are being reabsorbed in tubular cells. So there is this carbonic anhydrase supporting system mechanisms to convert carbon dioxide plus water, give us bicarbonate and hydrogen ion, that is acid. This hydrogen is secreted into the urine. Bicarb is returned to the blood to still cushion the effect of acid in the body systems. Hydrogen ion is goes out with the urine waste, and then bicarbonate is returned back to the blood. This dynamic maintains electrochemical balance and stabilizes pH. Remember, we said the pH is 7.35 to 7.45. Then we want to look at clinical relevance. What are the clinical relevance of these procedures? We look at acidosis. The kidney increases, hydrogen ion excretion, and bicarbonate reabsorption. Remember that hydrogen ion secretion is being secreted in the distal convoluted tube and the collecting duct, but they are being excreted with the urine out of the systems. While bicarbonate is what? Is being reabsorbed. That is when there's acidosis, that the level of the pH of the body system is low, maybe 4.0, 4.5, 4.5 point something. So this process happened. The brain, the hypothalamus will send signal to the kidney to do what? To increase hydrogen ion excretions. Okay, and bicarbonate reabsorption, so to make the body system to be what? To be the acid to be balanced. But when the alkalosis, that's the level of the body is, maybe you take too much alkaline water, maybe for 11.0, 11.0 pH, the kidney reduces hydrogen ion excretion. The information is sent Hello, I hope you are still with me.
Yes, we are with you. Yes, sir, we are with you, sir.
Okay, you can see my
Very
share,
good,
my screen.
No, sir, we can't see
No,
your screen.
sir.
You know, so let's see.
Not yet. I think it's your
let's
network.
see,
It's your
the network.
network. I think it's the network from your inside.
From my end, okay.
Hello, sir.
Hello, I'm listening. Go ahead.
No, I said we were lost for a while because we couldn't hear you again.
No, I paused myself. I had a call. I need to pick my call.
Okay,
So
sir.
I intended to attend to someone quickly.
Okay, sir. Okay, sir. No problems.
Can you see it now?
Yes, sir, we can see it
Yes,
now, sir.
sir.
All right. All right. Sorry, please, I hope I'm not too fast to man fast address of me. I'm a fast talker, man fast, man sorrow. So I'm not too far, you're not falling. Please call my attention. I'm willing to teach you, to explain over and over again. That's why I'm being paid. So I need to impart the knowledge. So if I'm not too fast at any point you don't understand, please call my attention. Okay? All right.
Okay,
Let's go
sir.
ahead. Now, do you understand how, because it may be, because I may say, write short note on renin, angiotensin, and aldosterone systems. It's just 2.5 mark. When I see how many pages. There's one man you're in the, I don't know, in the overall class. If I ask short note, you can write like 4 pages. But unfortunately, the man's handwriting is not too good. So I strained my eyes with my glasses. +2000. So So I may ask a question in the exams, and we have 14, okay. How many people have joined? More than 13 in one class, I not to join. Well, I'm not supposed to be here, that is here. All right. So I may say write short note on
the last person, sir, will be the AI taking the recording.
Okay. So I may say write short note on RAS, and then write short note on acid-base balance, acid-base regulation of the kidney. Exactly what I give to you is what you need to give to me, 2.5 marks. Please take note of that. Now, I won't go into deep to this renal clearance, all those, it may not necessarily, I'll just take one or two and then all that we can leave for information purposes. All right. Now, we want to look at what is renal clearance. When you talk about renal clearance, is this referring to the volume of plasma that is cleared of a specific substance? For example, if you are looking at renal clearance of bicarbonate, if you are looking for renal clearance of glucose, if you are looking for renal clearance of protein. So it's a volume of protein in plasma cleared at a specific substance, the specific protein of a protein by the kidney per unit time. Is it 1 hour, 10 minutes, 20 minutes? What's the volume of plasma protein that was cleared from the systems? That's what renal clearance. It's one of the tests you can use to assess kidney function, renal clearance. And the formula is clearance of the substance multiplied by, is equal to urine concentration times urine flow all over divided by plasma concentration of the substance in milligram per dl. Type of renal clearance, we have high clearance. That means substances freely filtered and secreted. For example, by antidiuretic hormone for renal plasma flow, can see low clearance, substance largely reabsorbed where they have low clearance. Please unmute yourself. I want to discuss this thing. When you say renal, what is the renal threshold? Value of glucose. When you say renal threshold value of glucose, what is the renal threshold value of glucose?
It was 180, sir.
180.
Can you please explain what do you mean by renal threshold?
Hello, sir. It is at the level at which the concentration of a particular substance will reach in the blood before it appears.
A round of applause. Excellent, excellent, wonderful. That's the maximum volume.
Yeah.
My network.
Yes, sir. Yes, sir. It is your network, sir.
Oh.
Sorry about that.
I'm going to round up. For that, okay.
You can't see your screen again, sir.
Okay, I will share it now. My sincere apology for for this interrupted
network.
Oh God. Let me quickly round up.
The network has not been fair today, sir.
I'm not happy at all. I just want to round up and then after that lecture, I need to take èrè àwọn teacher ọ̀run ló wà.
Iṣẹ́ sí.
Wọ́n ti ń jèrè láyé sà.
Èrè teacher ọ̀run ló wà. Next week, I mean, I'll be going to Kaduna. So I just want to do one or two lecture against next week. So I'll be able to, that was this year. But you see, for kí ló ṣẹlẹ̀ kí mo ń ṣe ẹ̀ náà. Sorry for the polite interruption. No. Ẹ má bínú sá, ẹ má bínú mà. All right. Can you see my screen? Okay, so when we talk about renal clearance, that is the volume of plasma volume, maybe protein, maybe glucose, that can be, that can be filtered, okay, through the kidney per unit time. So this is one of the tests you use to assess kidney functions. And like we are talking about low clearance, that is glucose is not expected to be found in your urine, protein is not expected to find in your urine. In case paraventure we see you, glucose, the blood, glucosuria, what happened? Well, if you say urea and the glucosuria, urea in the urine, what happened? You know, so they are low clearance. They are not expected to be. They are expected to be reabsorbed. And it's not supposed to be found in urine. We have glomerular filtration rate (GFR). GFR is amount of filtrate formed per minute. Amount of filtrate formed per just minute in 60 seconds. By a nephron in both kidney, not one kidney, it's both kidney. And it's used as a marker for kidney functions. The normal glomerular filtration rate is about 9 to 120 millimole per minute / 1.73 meter square in an healthy adult. So how do we determine glomerular filtration rate? Remember I told you during filtrations, I told you there's 3 pressure that is mounted on bone marrow capsule. And here is the pressure. Hydrostatic pressure, that's in glomerular capillary bone capsule. Okay, we have oncotic pressure. I told you 3 pressure. That's opposing filtration due to plasma proteins, and then we have filtration coefficient. That is determined by the permeability and surface area of the glomerular membrane. So those are the 3 pressure. So when you are discussing filtration, I'll be excited. I'll be glad to see that there are 3 pressure mounted on bone marrow capsule that lead to filtrations or ultrafiltration of those items. And the pressure are hydrostatic pressure, oncotic pressure, and then filtration coefficient. You explain them. Then how do you measure GFR? Ionic clearance test, which is a gold standard, but rarely used due to complexity. Creatinine clearance, commonly used approximately GFR, glomerular filtration rate, but can slightly overestimate due to tubular secretions. Then we have estimated GFR that calculated from serum creatinine, age, sex, race, and using formula like MDRD and CKD API. Clinical significance of in chemical pathology, this GFR is to assessment of renal function. The renal clearance test help diagnose and monitor kidney diseases, such as in acute injury or chronic kidney diseases. So before somebody can go for clinical transplantation, that means there's a chronic kidney disease, that kidney is very, very bad. I remember when I was still practicing on the bench in Imo State, then 1990, around 2000. So one guy just came into the lab. He came part. So I collected the man samples when I ran around the test. In fact, I could not be able to read that, the solution in my spec. So I need to do double dilution. When I do double dilution, the value is over. I got almost 230 something, very fat. So I was curious. I want to know who is the patient. I have to look out for the patient. What happened? Is it pre-analytical problem? Is it analytical problem? Is it a post-analytical issue that make that result to me? So I invited the man to my office, called them, started them that I'm a sat the man down, told him, okay, what happened? Are you okay? See the result. I show him my result. Say my result is actually correct. That he came from Germany and be diagnosed going to die in the next 1 or 2 weeks. He had to come back to Imo State to come and he want to die. I was shocked. So what am I saying? Essence that the urea creatinine, the glomerular filtration rate need to be assessed. The two kidney has been badly damaged, chronic kidney failure. So this GFR can be used to monitor, even when after you can use to be diagnosed, you can use to monitoring, assuming they've started treatment, medications. This can be done to monitor the progress of those, of the treatment. Okay, then you can monitor drug clearance. This GFR can be used to monitor those who that take drugs, local drugs. This GFR can be used to monitor the drug clearance for drugs excreted by the kidney, such as glycosides. Then diagnosis of proteinuria and glomerular disease. Abnormal filtration lead to protein loss in urine, marker of kidney function, urea and creatinine elevated, level indicated, reduced GFR. But the most important is Sister Sensi. It's a more sensitive marker. It's a gold standard marker than creatinine for me. It's more sensitive marker than creatinine for early kidney dysfunction. We all know Sister Sensi dysfunctions. The electrolyte imbalance, monitoring sodium, potassium, and bicarbonate level for disorder like acidosis and hyperkalemia. Understanding renal physiology, clearance GVRs, chemical pathology, critical insight, and diagnosing managed kidney. So go and read about renal plasma flow, maximal tubular reabsorption capacity, maximal tubular secretion capacity, urea clearance, creatinine clearance, iluline clearance, concentration dilution test, dilution test, renal failure, chronic diseases, and amino acid urea. Oh my God. That is where I will end today's class. How many hours have we stayed now? Almost 1.5 hours. I don't like talking too long. I always like my lecture to be as short as, even if possible, 30 minutes, and I'm done. So please bear with me. I don't like keeping a student in the class for 2 hours, 3 hours. No, because at this stage, the level of assimilation will be reduced. And for a student to do well, I know you are very busy. For a student to each lecture you attend for 1 hour, you need to read about 10 times for you to be able to retain 10% of what the lecturer have taught. For a student to do well, to have A, I know most of you don't need A, don't need first class. It's not useful for you again. You need to read every test, every note, at least 10 times for you to retain 70% of what a lecturer taught. And to the best of my ability, I think I'll be able to explain to explain to the best of my ability and my knowledge. I know, like I said, many of you know far, far better than I do. Please just accept my inadequacy, my poor presentation, and take me as it is. And I don't know whether we have questions so we can round up the class, or if you have anything to bothering you, your project, your seminar, please let's hear your view now before we round up. Thank you.
Thank you so much, sir, for the lecture. So do you have any questions for our able lecturer?
So, question, if you have anything, like I said, if you have anything to add to what I've said, practically your experience, you can share with us concerning this subject, matter on kidney, nephrons, urea creatinine test, reabsorption, electrolyte balance, So the floor is opened, and it's good for us to share knowledge or experience. Most of us have been on the bench for 10, 20, 30 years. Our Kolori bench, I think most of the Kolori bench. So the floor is open for your contributions. You can, to help the class and help the other people to share our experience. Do you want me to call name? Àwọn director tó wà ní Ọ̀ṣunmáni mẹ́jẹ́ kí n máa porúkọ. Is Ms. Oketi on the line? Ms. Olusola, okay. So what's online?
I'm still here, sir. I'm here,
Oh, yeah,
sir.
what can you? Can you please share your experience on electoral bench? Kí lẹ fẹ́ sọ fún direct on me. So, what do you want to share with us from what I know? What the better the lórí bench ti wà? Àwọn kankan mọ́.
Well, a lot of people have electrolyte imbalance. Like when they want to do surgery and they are now trying to analyze their E and U level. We see a lot of things on the bench, but the unfortunate thing is that physicians, they don't really dwell much on the imbalance. They just order it for ordering's sake. At times, those people will already be on the theater bench before ordering for it, so it's like it's not really useful. But in advanced countries, they make sure they do the electrolytes before carrying out any major surgery. Like me, when I have my surgery, there was even no E&U request. So they are not really depending on it. Maybe they are just using their initiative to carry out the surgery. But it's something that should be done before surgery. Thank you.
Thank you so kindly, man. God bless you. Mr. Timothy Olagunju, your experience too. Can you please share your experience with us?
As you've said, we have not been on the bench, but we've left bench for so long. You know, we are doing some of the statistical activities personally.
Okay, thank you. Mr. Fasasi, is it there?
Yes, I'm here, sir.
Well, it's already bench.
I want to buttress what my director has said. Though some of us have been unfortunate to be out of main clinical chemistry practice for a while, burden on the nature of HMB. I believe you understand what I'm trying to say, sir. But then when we push for chemistry as chemists, one thing we find out is that there's always this cost comparison from the admin. They're always looking at the cost of the infrastructure for clinical chemistry. Yet, like every facility does cesarean section, which I wonder, how would they be doing cesarean section without as basic as at least do the potassium? If you cannot do every E and U, do the potassium. Somebody you are going to place on anesthesia, you don't even know what the level of the heartbeat or the function of the cardiac system is like. They just do any. There was a case. There's this. I think it's now the National Assistant General Secretary for NMA. We used to work together before in State Hospital Oyo. I know the guy for never doing any surgery without E&U. He will do all laboratory parameters for his patients. And even if he has to do it outside that hospital, he will still contact me. Mr. Fasasi, please, I have a patient. Can you help me with the E&U? He will send the sample to me. He will never do that. But unfortunately, those that are his subordinates, because he's a consultant gynecologist, most of his subordinates, I've seen them doing, in fact, they can do 15 cesarean sections in a day without recourse to the laboratory, except for them to just say, can you type for the blood so that in case they need to transfuse. That's all. Even when you want to transfuse a patient, do we really even know the status of the heart so that you don't go into cardiac overload? Most of these things, as basic as E&U is, it is very, very essential. But they don't. I don't know why. You don't know what the status of the kidney is. You want to even transfuse a patient with blood. You don't know what the status of the heart is. You want to transfuse a patient with blood. You might be giving the person cardiac overload, which will result into renal involvement too. But when you talk, they're always saying, chemistry, to invest in chemistry is expensive. They would rather go. And most of the time, they want to rely on, and which some of us also encourage, which I don't encourage as a clinical chemist. We want to encourage using wet chemistry for clinical, for E&U, especially electrolytes. how accurate can we be when we are using reagents, wet chemistry reagents to measure our electrolyte, when we have other well-grounded and well-standardized techniques like using ISE, then using biosensors. We are not encouraging this. We still want to use spectrophotometric method, which I find very, very absurd in this age and time. I've never been a proponent of using spectrophotometry method for electrolyte evaluation. You cannot tell me with what we have in Nigeria with storage and everything, electricity and all the like, and we say you are getting accurate results. How accurate can you be? Even your control is deteriorating. So these are my little observations from the bench, sir.
Thank you.
Hello, sir. Hello, sir.
Yeah, Mr. Karim,
yes,
over
sir.
to you.
Thank you very much, sir. I think our case in usage is a little bit different because most patients are beginning to have a great awareness about their state of their health. In fact, in most cases, at times, some people say that small surgery, they want to waste their money for E&U. They see order for E&U and creatinine in UCH before any surgery. In fact, for a little abnormal results, or we target to be a critical result or alarming result, we follow up, down to the ward by meeting with those doctors in charge, either the consultants, and they appreciate that because recently one patient had done the test somewhere, and then when he got to the doctor now said that, okay, I still want to send you for the test, but not now. Now said that, okay, go and try this drug, and this patient insisted that, doctor, what is the fact to show that yes, I have to start this medication before the test? That you need to go for it was the patient that requested for the for the test. Meanwhile, the doctor had already discussed with the patient that, okay, before I can put you on this particular medication, we need to know the baseline. So telling us that even some patients too, though some people, they believe that coming to UCH might be difficult, might be so hectic, but at the end of the day, we have results. But looking at the awareness, I think most patients are beginning to have knowledge about what is happening to them. In fact, recently one patient came down to the laboratory and said, look at this, doctor. He said he has done the E&U and the potassium was 2.8 somewhere. And I said, okay, go and repeat it in chemical pathology. So lo and behold, when we repeated the potassium, it was 3.8. Meanwhile, the patient had consulted another hospital and he had already dislocated. So that's why it was able to build the potassium up to 3.8. So at the end of the day, the patient was fine, and the doctor too was, he came back to the department to say that, oh, you people, you are doing a great job. So, the thing may vary in different facilities based on the availability of the what they can work on. Thank you, sir.
God bless you, sir.
I have something to say as well, sir.
Okay, go ahead.
Can I go ahead, sir? Okay, thank you, sir.
Go ahead, sir.
All right, sir. I want to say that we should not always be on the defensive as well. We should educate our patients whenever the opportunity presents itself. If you observe what is happening now, you will see that because the patients are aware that they need to do tests before treatment, most times they are even the one that will be agitating. They will be the one to be telling the doctors that they want to undergo tests. And as a result of that, that is keeping the clinicians on the other end because they don't have option than to send these people because they are aware, they know the importance of carrying out those tests on them before placing them on any treatment. So I think the onus lie on us too to educate as much as we can, to create that awareness. You let people know why they have to do those tests, irrespective of the cost. And once they have that information, I think they will be prepared. By the time they are able to weigh the advantage and disadvantage of not running the test, then they'll be able to decide and press forward. So that's just my contribution, sir.
Thank you.
Because
Thank
the
you.
clinical outcome, our clinical outcome, that is why it is the way it is right now. Because even up till now, we don't still learn to do things rightly. Many of our clinicians, I don't know, maybe due to rivalry or whatever, they still believe they can still carry out empirical treatment, even in this 21st century. So it's very unfortunate.
Thank you. Thank you. All right. So that's important information I missed out when I was presenting on renin angiotensin aldosterone systems. So I said that when there is dehydration, you are dehydrated, there is no water in your body, so what happened? The hypothalamus will send signal to pituitary gland to release more ADH, that's antidiuretic hormone. When you are dehydrated, you don't have enough water in the body system. So what happened? Pituitary gland, we send signal. Hypothalamus will send signal to the pituitary gland to release more ADH. And this message will go to the kidney to conserve water. The water need to be retained in the body. You should not be able to pass out much water. And if you are hydrated, like maybe you are working, your office is AC, your car is AC, your house is AC, toilets everywhere is AC. The hypothalamus will send signal to pituitary gland to stop release of ADH, because when the ADH is not being released, the kidney will refuse. Will not release. Will release. Will release more water. In the upper this circulated tube. And it will lower the BP. The blood pressure will be lowered. So let us remember those two key mechanisms. Dehydration, what happened when you are dehydrated. If you don't take water, when you are hydrated, maybe rain is falling, the weather is cold, you are in Europe, most of people don't take, we don't need water. What happened? So we need to understand and know this basic principle. Thank you. That's what I want to add to the lecture. In absence, where is Ms. Okumola? As if she has gone, she has stepped out again. I can't see her in the list of the Mr. I hope you are. She's one. You are market attendance, Abi.
Yes, sir. I think it's her network.
She log in, log out. I've been monitoring the student. Weight of this man, the director in Mr. Akanji.
He was chatting me. I don't know why he's not here. He was still chatting on the general platform. I saw his chat. He asked the question. So I don't know why he did not log in. Possibly
because he has not been attending lectures. I know some people in this class. I know when there's lecture. He has not been attending lectures.
I'll speak to him about it, sir.
Thank you very much. For my student for seminar, please come up with something. Let me see what you are doing. Discuss with me. Let me see what you are doing. Please, right. I beg you.
Sir, can some of us use our project topic? That would just be excluding.
Yes, now. If you want to use a project topic, use your project. If you want to use better for you. If you want to use your project topic,
yes.
Use your project topic to help you. I was told the last time I discussed with the dean and said the connector says is it January or so. I don't know. Because that thing you will do, in first semester supposed to do seminar. This is what you ought to have done this seminar, the seminar presentation. Second semester we do another seminar or your proposal before your project. So I wouldn't understand the way I'm going to want to be. I know everybody must come to my place for their presentation, maybe 2 days weekend. You can do it.
We are considering using Zoom, considering the.
Why are you considering Zoom? Why are you considering that? Are you the dean?
No, I was discussing with him on the possibility.
He told me point blank that everybody must come physically for the seminar presentation.
We will do that now. If we could spare, if everybody could spare a week, I don't think 2 days.
No, it is not a week. It's 2 days.
No, what I meant is that the last exam, if we could all be there for 8 days, 9 days, 2 days will not kill anybody.
So everybody. 2 days. You are people at 60. Maybe 30 we do on Friday. The second part we do on Saturday weekend. So it won't affect
much work.
So I want to first since out there they can come, but they need to everybody there should be attended for that 2 days. But anyway, they can come see what the other people have done. Then we scrutinize their work, and then and it's a point. I think it's 2 credit units. That presentation,
Yes.
not something. It's a 2 credit
Yes, sir.
units. And so you need to be on ground. And then the way I don't know, we've not met, and you will do PowerPoint presentations when you are presenting. But when
Yes,
after
sir.
you will scrutinize your PowerPoint presentation, but to your supervisor, you are going to submit Microsoft Word.
Microsoft Word.
And when you are my student, I don't take even your project will not less than 100 to 150 pages. I won't take it. My own project, those who I'm supervising, their work not less than 150 pages. So I will not collect it. So you need to give me the background. I need detailed information about what I do. I want you to have clear understanding. But give me 150 pages, all total for your project work. For Ken part to those who are for, I don't know how many I'm going to supervise. So I'm just bury your mind, sit down, give me not less than 100 to 150 pages of your work. You can't give me 10, 30 or 40. No, I won't take it. So just please, let's look for time, talk to engage your lecturers, supervisor. If you're not your supervisor, you can engage someone else that will guide you on what you need to do. So the Microsoft Word will now be 60%. Your presentation is 40%. So when after your presentation, you put your Microsoft Word together, the front cover page, the introduction, the whole work, the conclusion, what have you, put it together and submit. You buy Sparaband and something go to your supervisor. It was going to grade you based on what you submitted. So it will be added to that 40 mark of your presentations. So that's how it's been done in our school. I don't know about my person. My person say they are still learning. So we see when we get there, we'll probably be able to cross the bridge. Thank you, and God bless you. Maybe, Madam Mary, are you aware you are the assistant class of this class? Me, ma, you off and on. I'm not happy.
Yes, I am,
I'm
sir.
not happy. I'm monitoring. As I'm lecturing, I click on the participant. I'm monitoring those people because when the attender is part of the CA.
Yes, sir.
All right. So all the best.
Hello, sir.
I do have a
Hello,
wonderful weekend. Yeah.
Sorry for, sir. I just remember something now, one of my interns, asked a question about this statistics as a good marker for early detection of kidney dysfunction, sir. Asked the question about why we didn't have such an, you don't have it as one of the available markers in most of the, tertiary institutions. So I did the reason I gave him was that going about this statistics is one, it's more expensive, and one might not be able to to come by or to afford it. Most especially that the patient might not be able to to afford it when required or requested for. I don't know, maybe you have some other a better information that one could give.
Okay, thank you so kindly, sir. Most of the thing we practice in Nigeria now. As of 2011, I went to UK. I was ashamed to call myself medical lab scientist. 2011, how many years now? Okay, so most of the things we are doing, they are outdated. They are not, they are no longer relevant. If you want to invest in a diagnosis laboratory, you need to. It's mindset and the poor leadership we have. All those are supposed to be existing in federal medical center, in government, state and government hospitals, in general hospitals. Okay, so but the problem is that people, the government, they don't even care. They care less about what do you do, what's the outcome of your result, So poor financing of the healthcare, the laboratory, no equipment to run those things. In Europe, in UK, for example, the company will give you an equipment. What you need to do, if it is a closed system, they will give you an equipment, and then what you need to buy is just to be purchasing the reagents. Meanwhile, the reagent is even more expensive. Look at it at long run; it's more expensive than the equipment they give to you. But they use to maintain their companies. While it is a closed system, they will have equipment that's a closed system. An open system. It can be used for several other options. You can buy reagent from other vendors to run. So the problem we're having that we don't have up-to-date equipment in Nigeria, except some few laboratories, some few owned by an individual, by private, they have all the system, they are working. The equipment are working, they use it. It's a gold standard. Sister saying it's a gold standard. It's one of the best marker for kidney function test. So what you need to do is just like before COVID, what happened? Almost all the laboratory, all the federal government institutions, they don't have enough equipment. But when during COVID, when the ravage of COVID, what happened? Everybody had to invest in it now, in diagnostics. I pray that God will help us. We get there by the special grace of God.
Thank
So
you, sir.
also in our capacity, you should educate most of us are directors, assistant directors, deputy directors. We are in a capacity to advise the management. You are part of management. Advise them, encourage them, put on your proposal, write a proposal. What's the function of sister? Say, what does it do? How can it help in diagnosing and to help you in your place of work? It's one thing for you to know something, don't do anything. Even if you do it and they are not taking action, the record, they keep your record that you've done your best, that the appropriate authority, they are not doing what is necessary, what is needed. So I pray that we get there. God will help us in Jesus' name.
Thank you, sir.
I'll go make it at 11:30, 38, almost 11:40. So any further question, contribution, comment before I call it a day? So remember tomorrow, which time tomorrow? 5, Abby?
Yes, sir.
I promise you, I won't stay more than 45 minutes, I'm done. We're going to talk about liver tomorrow. Anatomy of liver. We're going to talk about liver panel also. Liver
So please, sir, can you send this lecture notes so that we can share?
Yes, sir. Okay, send okay, I will send it. Please, if you don't see it before the day runs out, please.
I will remind you, sir. I will remind you. Thank you, sir.
Thank you.
Thank you, sir.
My director, Stella, all of you, Mary, Timothy, Stella, Dele, Kaniyat, Lawa,
Thank you, sir.
Patient, fine
Thank
bone.
you, sir.
This patient is a woman, a fine bone.
Thank you so much, sir. God bless you, sir.
Miss Patient, you are from where?
Niger Delta.
I'm talking to Miss Patient. Is it there? On mute, and let me hear you out.
Maybe Madame is working in the lab again. She's the one. She's always
in the lab.
She's always in the lab.
Where is he working? Hospital Management Board?
No, PPH, the
the Universal Lab.
Universal Lab.
Okay.
So she's always up.
I come to this year and come and see all of them. Most of them, I don't know them. I come around. When we are doing seminar, I will be like on Wednesday, Thursday.
We thought we are going to see you at the reunion, sir.
No, Pasasi, were you calling me?
It's Oga that is calling you.
Morning,
I said you are busy. It's
Oga. I'm busy. Good morning, sir. Sorry.
Good morning, madam. You are from where? We are from which state?
River State, Opobo Town. Rivers.
I know Rivers now. All my life, a quarter of my life, I live in Port Harcourt. I know Opobo.
Oga, well done. Me, I don't know road though.
No, Opobo. You go enter water before you get to your village. Your village is not to like a loser, small village.
King Jaja of Opobo. In the history. King Jaja of
Opobo. I'm a descendant.
So you be princess.
Secondary school or primary school.
Network no good though.
Hello, I can't hear anything. No,
Yes,
Fasati.
I think it is his network.
Okay.
So we might possibly have to end it since it's through the lecture.
So what inside you? Hello, Fast.
He say he don't know you.
Ah. No problem. Now one day you go know me.
Yes, ma'am.
Anna, how you dey?
We do.
Now, so we don't finish for today.
Yes, we have. So tomorrow 5.
Okay. So that thing where you send, make I begin work on them.
I beg, please. I beg.
You be Calabar. All right, sir. I'll get somebody to start on it.
Please, thank you.
All right. Later.
I go find time come around this week when they come soon.
Okay.
Yes, ma'am.
Just let me know.
Okay. No problem. Thank you. So I think we can exit. Let's go and enjoy the Owambe. All the whining and dining. So have a lovely weekend, everybody.